Good morning, everyone. Happy Sunday, the 17th of May. I'm super excited to be with you this beautiful morning in San Diego. It is 8:30 in the morning Pacific, 11:30 a.m. Eastern Time. I'm just excited about this wonderful and special Q&A because it is in honor of our Global Porphyria Day, which, as we know, is tomorrow, May 18th. We want the whole world to know about porphyria. We want the awareness, and everyone is doing a beautiful job already gearing up for the campaign that we have launched. One thing I wish you understood about porphyria. So if you haven't done it yet, I definitely want you to jump on the bandwagon on this beautiful campaign because it really will allow us to share our real stories and understand the reality of what we face every single day with porphyria. As we get Dr. Bruce Wang on the line, I just want to tell you a little bit about me. I am Myra Martinez. I live with acute intermittent porphyria. I have lived through paralysis and just like the typical nightmare that we hear about patients that don't get the diagnosis on time, hence why I am extremely passionate about making sure that we are constantly telling people about porphyria. My role within the UPA is I'm a patient advocate, which means that whenever a patient is having a difficult time, either they just got diagnosed and they are looking to find a connection with someone else that has porphyria, it is my job to go find a porphyria patient to connect them with. Here we are. Hi, Dr. Bruce Wang.
Hi, everyone. Hi, Myra.
Welcome. Super excited that you're spending this beautiful Sunday morning with us. I understand you are extremely busy, but thank you so much for making a time for all of us. As always, it is always impactful every time you come on. You always shed some light into not only what porphyria is, but also just I think every single one of us, when we walk out of here, we feel this sense of ease, like, okay, this is not as bad and as scary as it seems. So thank you for allowing us to create that breathing space. Dr. Bruce Wang is a porphyria expert with UCSF. He is in San Francisco. Dr. Wang, why don't you go ahead and introduce yourself for the rest of the crowd who might not know you?
Sure. Thanks, Myra, for that very kind introduction. I'm very happy to be here. Always happy to participate in these UPA Facebook Live events. Hi, everyone. I'm Bruce Wang. I'm a hepatologist practicing in UCSF, University of California, San Francisco. I run the Porphyria Center and Porphyria Clinic here. I'm also a porphyria researcher. We participate in the Porphyrias Consortium, which is a group of porphyria clinical centers in the US. We were established about, I guess 16 years ago now, and have been studying porphyria patients since, and run a research lab that studies basics of heme biology, especially in the liver.
Wonderful. And by the way, he does have patients not just in San Francisco. So if you're wondering, can I see him, even though they are not in San Francisco, the answer is Dr. Wang. Can they see you?
Yes. In fact, because porphyria is such it's a rare disease, and there are a few specialists that are familiar with it. I can even see patients from out of state.
That is wonderful to know. So absolutely reach out to him, his office. And if you don't know where to get a hold of him, reach out to the UPA office and we'll get you in contact with his office so that you can see him as well. I have the pleasure of calling him my doctor now. So super beyond blessed about him being a part of my medical team. So Dr. Wang, we are doing a porphyria, I guess, a challenge and or awareness for this particular year for Global Porphyria Day tomorrow. The prompt is to answer one thing I wish you understood about porphyria. So I'm going to let you answer that and then we'll jump in, okay? So
Okay.
finish that sentence for us. One thing you wish others understood about porphyria.
Yeah. Really good question. I'm going to answer this question as to as if because I think my answers would be a little bit different if it was another colleague asking that question versus a
Sure.
patient asking that question. I think I'm going to answer that question from as if as if a patient asking me that particular question, and my answer would be that I wish people knew that despite how rare porphyria it is, and probably how long and frustrating each patient's journey to get to the porphyria diagnosis was, um, there is a lot that is known, and there are a lot of resources that are available to porphyria patients about porphyria. In fact, in terms of rare diseases, we probably know more about porphyrias relatively than most actually other diseases. And the other thing is that the last 10 years or so has been, as a porphyria clinician and researcher, a really exciting time for porphyria, for development of porphyria treatments. We've had two new FDA approved medications for porphyrias. We've had several phase 3 clinical trials that have been completed with good, promising results. There are two current medications that are actively being evaluated by the FDA for approval. And if we, before these last 10 years, the only medication that we had that was actually effective, there was only one. So this is actually a really good time to be a porphyria researcher, because I think it's we're finding new options for porphyria patients. And also, there's a lot of resources available through organizations like the UPA. So it's a long answer, but basically, I wish people knew that you're not alone in this. There are a lot of resources available. It's still a difficult disease. Doesn't mean that we can solve all of your all of the issues, but that there's a lot of help available.
Absolutely. Beautifully said. Because honestly, when I got diagnosed, one of the scariest thing was in my head, not knowing who to turn to. I obviously at that time the UPA did not necessarily exist. This was 5 years ago, but understanding that there were others out there that were facing the similar situations, and now watching what science has done over the years, like you said, there are new medications in trial right now, things that are exciting happening for even our CE peers who have kind of been forgotten in so many ways because it's the one of the rarest. I love to see the amount of awareness and therapies that are being put out there, and that is a huge part of it is the UPA and the scientific board pushing the limits on this. So beautifully said, patients, we are not alone. Dr. Wang has hit it right on the nail, right in the head, that we are here to support you and making sure that you don't feel alone in this process. So ready to rapid fire?
All right, let's go.
Let's do it. All right. Do you ever see peripheral swelling develop after an acute porphyria attack, specifically AHP? And if so, what is the cause?
Yeah. I don't see that commonly after an acute porphyria attack. The way that I understand that we understand acute attacks is because of the underlying genetic mutation, and in conditions where especially the liver needs to make a lot of heme, where the body ends up building up two chemicals: ALA, delta aminolevulinic acid, and PBG, porphobilinogen. These two chemicals, probably ALA is the bigger culprit than PBG, are damaging to nerves in the body. And we think that the nerves in the abdomen are most sensitive to really high levels of ALA and PBG. And so pretty much, nearly everyone experiences severe abdominal pain, as well as then you get associated nausea and vomiting. You can get peripheral nerves be affected as well. So you can get weakness, numbness, and the central nervous system can be affected as well. So you can get mental status changes. Now, there are nerve innervations, for example, to blood vessels. I can imagine physiological scenarios where nerve damage could lead to perhaps changes in blood flow peripherally that may lead to swelling. But in clinical practice, I rarely see it. I can't rule it out, but it's not a commonly seen symptom.
Understood. Thank you. Does laser therapy for hair removal or light therapy for psoriasis trigger flares in variegate porphyria that you're aware of?
For variegate porphyria, yeah. That's a good question. I'm actually going to try to expand that answer and talk a little bit more generally about for cutaneous porphyria patients. And in here, I'll also talk about for erythropoietic protoporphyria as well as XLP patients. So for those patients who have cutaneous porphyrias. And variegate porphyria and hereditary coproporphyria fall into a slightly special category because they can cause acute attacks with accumulations of ALA and PBG, just as I talked about, with the neurologic symptoms. But because of where the defect is in the heme pathway, those patients can also accumulate a different set of chemicals called porphyrins that are light sensitive. And those patients can develop blistering skin lesions. And for variegate and hereditary coproporphyria patients, those symptoms that they can develop are very similar to patients who have porphyria cutanea tarda, for example, as well as those patients who have congenital erythropoietic porphyria, CEP. Although CEP patients, because those chemicals are even higher, have additional skin problems that can develop in addition to these blistering skin lesions. So in those patients who have elevations of porphyrins, these are light sensitive chemicals. And so light exposure has the potential of activating these chemicals. And then these chemicals absorb energy from the light, and then they release that energy immediately, basically to the surrounding area, and that's in the skin. And that's how we think blisters develop in patients with variegate porphyria or PCT and CEP. In the protoporphyrias, those patients who have EPP or XLP, the porphyrin that accumulates protoporphyrin has slightly different chemical properties. It's very water insoluble. It may not diffuse out directly out into the skin quite as much. And so it doesn't cause blistering skin lesions. The skin doesn't separate, but those patients get acute pain with light exposure. So it really depends on the wavelengths of light that these light sources, depending on the light source that the patient is being exposed to. So for so both EPP and variegate porphyria, it's mostly light waves in the visible spectrum of sunlight. Right? And the reason I want to mention that is sunscreen, which we most people use to help protect ourselves to prevent against skin cancer, are specifically meant to block wavelengths in the ultraviolet range of the light spectrum. And they don't actually block the wavelengths of light that can activate porphyrins. So they certainly provide really no benefit. The UV light protection really provides no benefit for EPP patients, nor does it provide benefit for variegate and PCT patients. So that's important to note. So to go back to the question, laser light therapy, other kinds of light therapy for the hair, it really actually depends on the light source. Laser, probably not. The wavelengths are probably not long enough in the wavelength spectrum to activate porphyrins. UV, tanning beds, UV lights, depending on their light source, they actually do emit light in the visible spectrum, and that can trigger, certainly that's triggered painful episodes for EPP patients. So that I'd be much more careful about.
Understood. Wow, thank you for that explanation. I definitely learned a lot about VP right there just with that answer for sure. This is a mom asking specifically about a daughter that was just diagnosed with porphyria and lupus. Doesn't say which type of porphyria, but the question is, how to tell the difference since both symptoms can be very similar. How can they tell the difference between a flare, porphyria flare, or a lupus flare?
Yeah, yeah. So here I'll talk primarily about acute porphyria symptoms, as I'm imagining that's those are the types of where you can see overlap with something like lupus or any other systemic disorder. And I think it's a very important question, and I'll generalize this. One of the reasons acute porphyria is so difficult to diagnose is that its symptoms are broad, and the symptoms during acute attacks, abdominal pain, nausea, vomiting, weakness, numbness, those are nonspecific. There are many other things that present that way. Acute porphyria, if you're having an acute porphyria attack, just based on the symptoms, it's difficult to distinguish what your symptoms are due to. Is it from acute porphyria versus a whole large list of other things? Is it acute appendicitis? Is it gallstones? Is it endometriosis? Is it gastritis? Is it pancreatitis? Now, lupus is an interesting other question. Lupus is another disorder where its symptom presentation is very broad. So in this particular case, you've got two conditions that can present in a variety of ways. Many of those symptoms can overlap. Okay. And I think this brings up a good general question, which is even for those patients with confirmed acute porphyria, who have experienced, acute porphyria attacks and are intimately familiar with their own symptoms. Okay, I still think that it's really important every time that you have a severe episode that we do make sure that we don't miss something else, that we rule out other things. Okay, so for acute porphyria attacks, the good thing is that we do have a very specific way of figuring out whether or not symptoms are due to acute porphyria attacks. Because if the symptoms are due to acute porphyria attacks, then at the time that you're having symptoms, right, and it can be shortly after, because the levels of these chemicals, ALA and PBG, stay elevated, typically for many days, oftentimes for many weeks after an attack. Okay. The key here is to do biochemical evaluation, is to check for high levels of ALA and PBG. All right. And now in patients who have recurrent attacks, the key here is also to know what a patient's own baseline is and what we're looking, because in patients who have recurrent acute attacks, their levels of ALA and PBG may be elevated all of the time. And so there, what we're looking for is higher levels than that patient's own baseline. Okay. So the way that I think about acute attacks is if a patient's having, with known acute porphyria gene mutations, is having a set of symptoms, all right, those symptoms are clearly due to acute attacks if at the time that those patients have those symptoms, their levels of ALA and PBG are higher than their patient's baseline.
Understood. What happens if they are on Givlari and that is consistently suppressed?
Right. So that's a really good question. And we are learning actually new things about acute porphyria attacks and the biochemical profile of attacks since givosiran has been introduced. So for those patients who don't know, givosiran is a relatively new medication that has been FDA approved for treatment for prevention of acute attacks in those patients who have at least 4 attacks per year on average. And the way that it works is that it suppresses the liver's ability to accumulate ALA in particular. So in those patients who are on givosiran, actually the same principle that I just mentioned about monitoring the levels of ALA and PBG still applies. What we tend to see now in patients who are on givosiran is that the level change, the degree of increase of ALA and PBG is much less than those patients before they were on givosiran. So I'll give you an example. Patients may have baseline levels let's say I'm talking about a patient who has recurrent attacks, who maybe has an attack every few months. That at baseline, those patients may have, before starting on givosiran, ALA and PBG levels, ALA maybe at 10 to 20 at baseline. And then in the middle of an acute attack and for, a day to week. So afterwards the ALA could be as high as, 30, 40. The PVG could go up to 100. Okay. And then as they get back to their own baseline, those levels drop down. On givosiran, at baseline, generally we expect the patient's ALA to be totally normal. In fact, it is really suppressed. It may be 1, it may be less than 1. Okay, and these numbers I should mention that just saying the numbers, but there are units for them is really important whenever we check urine for ALA and PBG, that we also check a urine creatinine with it. It just helps normalize these values, and all of these numbers that I'm mentioning should have units of milligrams of ALA or PBG per gram of creatinine. Okay, and one other thing I'll mention here, which is we're talking about acute attacks of porphyria, and in that setting, the levels of ALA and PBG are very high. There's no need to do a 24-hour urine collection when we're measuring these levels. Random urine is enough. Okay, so when you're on givosiran, the ALA should be down to less than 2 milligram per gram creatinine. Now, if that patient's ALA gets back up, even if it's just a 5 or 6 or 7, all right, that's a little unusual because givosiran generally it's a really powerful drug. It suppresses ALA really quite well, and so that's what I'm looking for to correlate with symptoms. So if a patient comes to me and says, look, I'm feeling similar kinds of symptoms as I used to when I have my severe acute attacks, okay? And oftentimes patients who are on givosiran will report that the general nature of the sensation feels similar. The characteristics are similar, but maybe the intensity is a lot less than before.
Correct.
Right? That's a pretty typical description of the kinds of symptoms. And what I have seen is that then when we look biochemically, the ALA is elevated relative to that patient's on givosiran baseline. And as long as that's the case, I still consider that an attack. And that attack should still be treated. And we treat that with panhematin. Okay, so that's typically what I see. There is another there's another scenario biochemically that we have seen, which is when patients are on givosiran and then they start feeling similar symptoms as they've had before, and we check ALA and PBG, and we've seen scenarios where the ALA doesn't change. It's still less than 2. But the PBG now is higher than the patient's own baseline while they're on givosiran. All right, that part we're not quite sure what to make of that just yet, because most of the other studies that were done to understand what's causing the nerve damage in acute attacks has pointed to ALA as being the primary culprit. But we've now collected some information to show that patients on givosiran can have symptoms that feel like their previous attacks, but biochemically, the only abnormality we see is that their PBG now is higher than their on givosiran baseline. And others, I know other porphyria providers have treated that also as an acute attack and treated that, with panhematin, for example, also. But I mentioned that just as another a scenario that we have seen now. Again, we're learning new things about porphyria with introduction of new medications that potentially can change the nature of these disorders. But in general, I still follow the urine biochemistry for ALA and PBG. And if they are elevated, even by a little bit compared to their baseline on givosiran, I certainly would still treat that as an acute attack.
Understood. So from a expert standpoint, take a brand new patient that has been diagnosed with AHP, would your recommendation be for that patient to work, maybe even kind of nudge their doctor a little bit if they might not be a porphyria expert, to consistently do weekly, biweekly, monthly at a minimum ALA and PBG random test, just so that they have that understanding what their baseline is?
Definitely. I think especially, in my own practice, that's what I do. What I want to know about the patient is, and I always tell my patients, I would like to know over the course of the next several weeks, next several months, I'd like to know the pattern of your body's accumulation of ALA and PBG, how that correlates to how you're feeling. Does your level stay normal the whole time and then only during attacks come up? And then how long does it take to come down? In those patients with recurrent attacks, what tends to happen is the body slowly accumulates ALA and PBG. It goes up, 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 up until it gets above a certain level. Then you have an attack, and then maybe you get treated, panhematin, or maybe it's a monthly givosiran injection, whatever that brings it down, and then we see then over time does it
The
accumulate again.
cycle.
So yes, repeated testing of urine ALA and PBG. The interval that you need to do this depends on how frequent your symptoms are. Patients who are having symptoms on a monthly basis, I'd certainly want to check it at least once a month. In fact, I'd like to check it in between as well. Right?
Right? So you can
Patients who
get the
have, yeah,
baseline.
that's right. Patients who are having symptoms every 2 weeks, and I may be checking it weekly for a little while, just so that we can track and find out, learn exactly what your own body's is doing in terms of ALA and PBG accumulation.
And I just want to share while I'm here on this particular piece, Dr. Bruce Wang, you were actually one of the key doctors in helping me understand that, because I've been diagnosed for 5 years, yet I have a great hematologist besides you, but she was not a porphyria expert until she started working with you, that now she understands the power of understanding what that baseline is. So until I started working with you, I didn't know what my baseline was. I had no idea, because I wasn't checking weekly, monthly, no idea. So I thought I was on these constant recurring flares, what I thought that they were attacks. And now I'm just learning that as I'm getting closer to my givosiran shot, my body is definitely begging for that next one, because it does creep up. So I have seen the power of just understanding your own body, understanding what happens biochemically in our own bodies. And I can't recommend to all the patients out there with AHP to ensure that your hematologist or hepatologist, gastro, whoever you're working with as your porphyria expert, to ensure that this is something that's being tracked, because I have seen the difference in my life, and I can now prepare when that next flare that I would have thunk that it was a flare putting me in the hospital. Now I know what to do so that I can avoid the hospital. And it's been 3 months since I haven't been in the hospital, which is great. I know this is not about me, but I'm really, really hoping that someone else out there who might be experiencing these repetitive flares can understand the power, the value of being able to just know yourself, but also understand what is happening. Because the other thing that can do, as you explained to me, is that then that gives you options. Do you increase the givosiran dosage? Do you change the interval? Talk to us a little bit about that.
Yeah. So that's a great comment. Thank you for sharing with folks your own experience on this. And yes, and that's a great question. I was actually just going to say, as you were mentioning this, was that the other reason to really help, we want to track what. We want to track what the disease activity is. Really, I think about ALA and PBG as reflecting what the disease activity is in your body. And everyone's pattern is going to be a little bit different. Your
Right.
set point for, when you start developing symptoms is going to be different than the next person. How long it takes for you to accumulate, ALA and PBG above that, or what triggers ALA and PBG to accumulate above that, that's going to be different, for each person. And so tracking those levels allows you to potentially predict a little bit and help, prepare and prevent. But the other thing is, because we have treatment options, we have panhematin as a treatment to stop acute attacks once it starts. We have givosiran as a way to prevent acute attacks. Knowing these levels allows us to tailor and really we are personalized. We're able to personalize the treatments for each person. So do you need, how often do you need givosiran? Right? Is it, what is the correct, dosing? We actually don't change quite as much with givosiran, but givosiran intervals is something that can be tailored individually. We always start off every 4 weeks injection for patients. But over time, for some patients, that can be spaced out in a safe manner. for patients.
Yes.
Panhematin, we can schedule that on an as-needed basis. You can schedule it on a pre-scheduled sort of preventive basis. How often you do that, when that happens, again, we need to know what your own disease activity is and the pattern of it, and then we can tailor the treatment so that really the long-term goal is to prevent attacks. And then if you are ever to attack, to stop them as soon as they occur, because every attack is an episode of nerve damage, and nerves are just cells in our body that don't heal very well, and so we really want to prevent recurrent attacks, repeat attacks, and we certainly want to prevent prolonged attacks, because that's when nerves run the risk of not being able to heal well afterwards.
Absolutely. Thank you. The next question, can you describe how porphyria causes headaches and migraines, and do they typically occur in every attack?
Yeah, so porphyria, I've seen many patients who then in the middle of attacks can also get headaches. This now headaches is a whole other category of symptoms with many different causes, including and a lot of these are actually not very well understood. Even migraines as a whole category of diseases, the pathophysiology of migraines, there are different types. But there can be a lot of potential overlap between why having high levels of ALA and PBG and having temporary episodes of nerve damage in the brain, including nerves that may innervate blood vessels in the brain, and during episodes you may be affecting, not to the point where you're going to cut off blood flow to the brain and have a stroke, but you might affect it enough so that now triggers headache types of symptoms. So so we certainly see it, but we also can have, we have patients who separately have a headache issue, migraine issue, and then those can be triggered by acute attacks,
Right.
or you're having an acute attack and that now triggers a migraine episode, right? So so it gets it can be a little complicated, but generally though, I will say we certainly see headaches is occurring during acute attacks. That can be as a result, direct result of the acute attack, but also it can be an acute attack triggering a separate pre-existing headache syndrome. Yeah, the reason I mentioned that is that the treatment for the headache syndrome is quite different than the treatment for an acute attack, right? So we can stop your acute attack with panhematin infusions, but if even after eating panhematin, let's say your other acute attack symptoms, the abdominal pain goes away, the nausea, vomiting goes away, but the headache is still there, then now you're going to need your headache treatments as well, in addition to treatment to stop the acute attack.
Yes, and I highly recommend for patients that are experiencing repetitive headaches and migraines to work with a head specialist, because I know in my case, my flares are so severe, I do get those horrific migraines where if I didn't have the Botox and nerve blockers every 10 to 12 weeks,
Mhm.
I could not survive. The pain
Right.
is just beyond ridiculous. So having added an expert in that field, in conjunction with working with you and the rest of my team, has really made a huge difference. Quality of life for us with porphyria is something that we constantly have to balance, and it seems like we need an expert in every area in order for us to survive and just live the best quality of life that we can with this disease. So it sounds like you're approving that is the best route to go if a patient suffers consistent migraines.
Yes, and I think you bring up another good point here, which is, we're talking about porphyria here as its own kind of separate entity, and even within porphyria, there are 8 different types of porphyrias, but a lot of a lot of different health conditions can affect each other. So, the person earlier, the mom who asked the question about, relationship between porphyria and lupus, those are two, these are all systemic illnesses. Porphyria is a systemic illness. We know what the specific mutation is. In some case, we know what the specific chemicals that accumulate are. We know where they're accumulating. But the effects of these elevated chemicals can occur and do occur throughout the body, and all kinds of body organs are affected, and so they can trigger and interact with other kinds of medical conditions that oftentimes are also systemic conditions. So it is important. The way that medicine is practiced, we tend to focus our own little box of disorders. And a neurologist will say, well, I'm mainly focused on the brain and the nerves, headaches or specific types of symptoms. But it really is important to get the specialists to talk to each other so that we're coordinating our care.
Yes, sometimes it feels like we spend a good chunk of our time going from one doctor to another, and it's just unfortunately part of a rare disease. I believe that it's very rare to have just only one doctor because of the multiple symptoms that we're constantly dealing with. So,
Right.
very good point for sure. This is probably going to be a long conversation, still on the vein of AHP. Can you explain how symptoms progress during an AHP attack and also the symptoms that appear after the attack?
Yeah. So we've already talked about this a little bit in AHP. Your body starts accumulating. The liver basically is producing high levels of ALA and PBG that gets out into the rest of the body. So a couple of things here. Timing of acute attacks. The levels of ALA and PBG in the body don't tend to accumulate all of a sudden. It accumulates over time. Generally, we're talking a few days. So typically, and this is especially true of patients who have just a few attacks in their lifetime. The situation probably may be a little bit more different in patients who have recurrent attacks all the time because their levels are high all the time. But in patients who, let's say, just have a few attacks in their lifetime, generally it's a slow on-ramp of symptoms because it takes a while for ALA and PBG to accumulate and get spread out to the rest of the body. So we think the nerve sensitivity to high levels of ALA and PBG are different. As I mentioned before, we think that the nerves in the abdomen and probably the autonomic nerves in the abdomen are probably most sensitive to high levels of ALA. So abdominal pain is the most common symptom. Many people say that that's also the most severe symptom, okay? But it also tends to occur pretty early. Oftentimes, this is just speaking generally now, all right? Because everybody, each patient's specific experience may be different. But in general, then the peripheral nerves are probably the next to get hit. And then you start getting weakness, numbness, arms, legs. That over time it can progress, and then eventually it starts peripherally, and then it comes in towards the middle of the body. A dangerous sign for a prolonged attack that isn't treated, or attack that then during treatment are treated with additional medications, additional triggers that even worsen the attack. Eventually, the nerves that innervate the breathing muscles, the diaphragm, can be affected. That doesn't tend to happen within the few days. We're generally talking a week, 2 weeks, into an attack, and usually that attack is continuing. It's still getting worse. You're still accumulating higher and higher levels of ALA and PBG, but in very extreme cases and most severe cases, patients can have trouble breathing. Okay. And in that case, you actually need to be put on a mechanical ventilator. Unfortunately, fortunately, deaths due to acute attacks are much rarer now. But in the past, that probably was one of the biggest reasons, common reasons for deaths during acute attacks, is a prolonged attack that made the respiratory muscles paralyzed. Okay. So that's a really severe but pretty late complication. Central nervous system effects, changes in mental status, and things. Those also tend to occur, a little bit after the abdominal symptoms start. So this is during an acute attack. And now sometimes, the attacks actually oftentimes will slowly go away on its own, because whatever trigger that caused the liver to make more heme and then accumulate ALA and PBG, if that trigger goes away, then the body can slowly get rid of ALA and PBG. We can speed up that process by giving the body heme. All right. And that heme goes to the liver, and basically we're telling the liver, stop trying to make heme. So that's how panhematin works. Elsewhere in the world, heme is given as heme arginate, but they work in the same way, right? And the liver stops trying to make heme, and then now we're no longer accumulating any more ALA and PBG, but still it takes a few days for the body to get rid of all of this excess ALA and PBG. So even while you're getting panhematin during an acute attack, it oftentimes takes about 72 hours on the third or fourth day of your hemin infusion before you start feeling better. But then once you start feeling better, a lot of patients describe all of a sudden, then it's kind of all of a sudden I feel much better right away.
Right.
Okay. So that's if we can lower the ALA and PBG pretty fast. But on attacks that kind of stop on its own, it might drag on for quite a bit longer. Okay. Now, symptoms after acute attack. During this acute attack, your symptoms are because certain, these different nerves in the body are being damaged by high levels of ALA and PBG. So how long the symptoms last really depends after after an attack where the ALA PBG has come down. Really depends on how long those nerves were damaged and how much the nerves are damaged by ALA and PBG. Okay, so a really severe prolonged attack that goes on for a week, 10 days, 2 weeks. Many patients, you may have many weeks to several months of residual symptoms where you're feeling, because it's the same nerves that are not yet healed, you may feel similar symptoms as you did during the attack, but maybe they're lower in intensity. Okay, and this is the reason we want to identify the attacks and treat them as quickly as possible, because it will shorten your recovery period afterwards. Right? In the worst case, if you have I've had patients who have just one really severe attack, but it's a really prolonged one, and that can cause nerve damage that takes many months to years to fully recover from. Okay. The other where we see this, the more common scenario are in patients who have many attacks that have accumulated over their lifetime. And those patients can also eventually develop even permanent nerve damage to certain parts of their body. And then they will have certain symptoms that keep coming back, even when the ALA and PBG is no longer elevated.
Right. And then that's really where the neuropathy can kick in as well. And we're left with neuropathy long term.
Correct. I mean, the way that I think about this is when you're having an acute attack, the high levels of ALA and PBG are actively damaging the nerve. So you are having neuropathy symptoms. Okay. But when the levels of ALA and PBG go away, if those nerves haven't been damaged too much, they will heal on its own. Okay. But the more those nerves get damaged, the slower it takes to heal. And at some point, those nerves may never heal if there has been either severe enough damage or long enough damage or enough repeated damage. And so that's what we want to avoid. That's why we want to try to prevent attacks, and we want to try to treat attacks as quickly as possible. Because once the nerve damage has persisted, you've got neuropathy that is present without elevation of ALA and PBG, that becomes much harder to treat.
Yes. And it's extremely painful.
Yeah.
For sure. Thank you for that. Next question. I recently heard a doctor in England speak about a network that they have that is a 24-hour hotline for doctors of porphyria patients or suspected porphyria patients. They are there to help with treatment advice and to answer questions. Do we have anything like that in the States that you're aware of?
Yeah. We don't have a formal network like that. So in the UK, I know the group there. So there's a few in London, there's a few in Cardiff, and they sort of they share their patients and manage all the patients together. Um, uh, in the US, there isn't. So we do have a similar network. We just don't have a explicit patient contact system that's put in. But I think in this country, we essentially have something quite similar. So, for example, the UPA, I think, is available all the time, and
Correct.
they, if you're a patient, you reach out to the UPA, they can connect you to a porphyria expert. And because I get questions from the UPA all the time, and it could be questions like, for example, drug safety. Somebody who says, "Oh, I need to have this surgical procedure, and I need to be on this. My doctor wants me to be on this medication, and it's tomorrow. Is that safe for me?" And we'll answer that question. Right away, because we get text messages and emails from them. I would say most porphyria physicians in this country uh, basically, realize that for our porphyria patients, they don't really have anybody else to be able to
Right.
answer their porphyria questions. So I give all my porphyria patients my cell phone number, and they reach out to me. They can reach out to me whenever. I always tell them, look, if you're having an attack, call me. If you're ever in an emergency room, call me or have them call me, and we'll walk them through what to do. So so I think in this country, our patients can have the same access to the same level of care. We have it through both the UPA and then the our own network of porphyria experts.
Absolutely.
Here.
And I do want to remind every single patient listening or caregiver that regardless of time and day, they can reach out to the UPA and someone is checking that consistently. We will make sure, because I've gotten calls in the middle of the night where I'm making a phone call into that emergency room, walking the patient through or the caregiver through what needs to happen, being on the phone with a doctor. And if I can't solve that, then that's when I engage a Dr. Bruce Wang, Dr. Carl Anderson, you name it, from our scientific board there. That's what they're here to do. So we do have that. Might not necessarily be a 1-800 hotline per se where you get the doctor right away, but the UPA allows us to be able to connect you to that doctor that you need so that if you suspect porphyria, definitely reach out to us. We'll walk through the testing that needs to be done because it is very specific testing. It can't just be, something that a doctor thinks about and then they think they're going to get it on some sort of report unless they're actually physically thinking about that, which you can talk a little bit about that, Dr. Wang, that if it's suspected, there are very specific tests. Am I correct?
Correct. So, in the acute porphyrias, what we wanted to check is random urine tests for ALA, that's delta aminolevulinic acid, PBG, that's porphobilinogen, and also a urine creatinine. Okay. For cutaneous porphyria patients, so it depends on what type of symptoms you have. If you have blistering skin lesions, so this applies to PCT patients, CEP patients, variegate porphyria and hereditary coproporphyria patients who have blistering skin lesions. What we want to check is also urine test, and also a random urine test is fine. Don't need a 24-hour collection. But now we're looking for urine porphyrins, and we're looking for fractionated urine porphyrins. For those patients who have protoporphyria, if you're having symptoms of acute pain with sunlight exposure on the sunlight exposed areas, parts of the skin, may have some redness, may have some swelling with it, but it's mostly burning pain with sunlight exposure. You want to do a blood test, and you want to do a blood test where you're looking in red blood cells, so red blood cell, or also called erythrocytes, and you're looking for measurements of something called protoporphyrins. So for the EPP and XLP patients, you're looking for erythrocyte protoporphyrin levels. So, so yes, depending on the kind of porphyria that you have, we are looking for slightly different things. These are all intermediates of the heme biosynthesis pathway, but depending on what kind of symptom, we're looking for slightly different intermediates because it's the accumulation of those specific intermediates that cause the different kinds of symptoms that are present across the different porphyrias, whether it's nerve damage and acute attacks, blistering skin lesions and PCT, or acute pain in protoporphyrias.
And this is the reason why doing this in such a day like global leading up to Global Porphyria Day is so important, because the awareness of it is so critical. This illness is invisible. It won't show up in any other testing unless you're looking for those specific testings that you just mentioned. So let's all do our part as caregivers and patients with this disease to be sharing as much as possible in teaching others about, one, how to suspect and look for it, and most importantly, understanding that without these specific testings, we cannot be diagnosed.
Correct, correct. Yeah. The standard blood work, urine test, imaging test that patients can get in an emergency room or in, typical checkups with their primary care doctor, they really won't reflect abnormalities in heme biosynthesis. They typically don't. I mean, I think really the only extreme area that I can think of is with CEP patients who have such high levels of porphyrins that their red blood cells are lysing and they're really anemic and need transfusions. But in those cases, that ends up being a pretty clear sign.
Right,
But for the vast majority of porphyria patients, typical workup doesn't reveal what the issue is.
right. This person says, I've only had 2 attacks. They have AIP, and they have been hospitalized twice for those acute attacks, and that was 13 years ago. I was told back then I could never go on to HRT, as I have not had an attack for so long. Would you suggest I go on to HRT?
Yeah, yeah, really good question. So, we've been talking, for acute porphyria, mainly on recurrent attacks thus far. But if we take a step back and just look at, how many patients are affected, and we'll specifically talk about acute porphyria here. A couple of things that I think is good to know. Number one, the presence of mutations in the acute porphyria. So we'll specifically here talk about acute intermittent porphyria, which is the most common one, okay? It turns out 1 in 1,500 people in the general population has a disease-causing mutation for AIP, okay? That's a lot more common than we previously thought, because the number of patients who ever have any attacks, even if it's just one, all right, for AIP, it's probably closer to maybe 1 in 50,000, right? Maybe 1 in 100,000, depending on, where we're looking, right? So what this means is the vast majority of people who have the genetic mutation never have attacks. All right. And actually, if you just think about even within your own families for patients who have AIP, that probably does make sense, because this
Right.
is a genetic disorder where you only need one mutation, and that mutation is passed on from one generation to the other. Everybody who has acute porphyria has AIP. There's, all of your first degree relatives, each one of them has a 50% chance of having that same mutation as you do, right?
Mhm.
But while symptoms of acute porphyria attacks do tend to run in families, but you probably also have other family members, and sometimes it skips generations altogether, right? So mutations much more present, much more common, but attacks not so much, right? But now if I take 100 people with AIP who've all had attacks in their lifetime, okay, probably 90, maybe 95 out of those 100 people will be like this particular patient who asked the question, who has just a small handful of attacks in their entire lifetime. Okay. And I bet around those times that they had attacks, if I had, if we had full access to all the information about all the kinds of exposures, medicines, other things that happened to them around the time, most of the time we can find some specific triggers that made their bodies, their liver in particular, have to make more heme at that time. Okay. So really, the patients who have recurrent attacks is a pretty small percentage of all patients who have mutations, and a pretty small percentage even of all patients who have symptoms, who have acute attacks. It's probably maybe 5% of all people who have acute attacks or have recurrent attacks. Okay.
Okay.
So the vast majority of patients who have had attacks, they've only had a few attacks in their lifetime. And generally, those attacks won't come back unless you get exposed to something that's really triggering. Okay. So what are those things? And to go back to this patient's question, what do I have to avoid? All right. So yes, hormones do increase the production of heme in the liver and can trigger attacks. Okay. What else do we know about that? Well, it tends to be changing levels of hormones, and it tends to be progesterone more so than estrogen. Okay, so one other thing to note is that acute attacks in much more often in women than in men. It's probably 8-2, maybe 9-1 ratio, much more frequently in women. But in women, typically the attacks will go away, and your risk of having attacks will go down very significantly after menopause. And that's because you no longer have cycling levels of hormones. And again, it's probably the cycling levels of progesterone. That's the bigger deal. Okay, so for this particular patient, the way that I would recommend is actually, I would ask this patient, go check a baseline urine ALA and PBG. Figure out what your baseline is right now. My suspicion is that it's going to be totally normal because the last attacks was 13 years ago. Okay, that gives me an idea about the relative level of risk that this patient has to have an acute attack triggered. Okay, the more normal the ALA and PBG is, I think the less likely they're going to have a triggered attack. Okay, and then I would say this is a risk benefit analysis that needs to be assessed here. And this applies not just to hormone replacement treatment, but to also any medications, right? So we haven't talked much about drug safety in acute porphyria, but basically a lot of medications can induce acute attacks because they make the liver have to make more heme. All right. And there's a whole website out there with drugs, with known drugs that are either safe or unsafe. Okay. And I really think about hormone replacement treatment along the similar lines. It's also something that can trigger acute attacks. And what we're trying to figure out here is, what is your own personal risk of having an attack? What is the potential benefit of being on this treatment? Right. And then we try to balance that out. So if you have to be on hormone replacement treatment, I would say estrogen better than progesterone. Okay. Ones that could be stopped, because in case you induce an acute attack, we would want to be able to stop it. So, if if all things being equal, I would prefer daily pills than, let's say, a patch.
Right.
But the levels also matter here.
Okay.
How high are the levels, right? But it is a risk benefit analysis, and oftentimes we can determine what that risk for you is by knowing what your baseline ALA and PBG is. Can we establish access to panhematin for you in case you have an acute attack? And then now, if we can do all of that, well, then we can start you on whatever medication you need, including hormone replacement treatment, monitor your ALA and PBG levels after you get started on it. We have a backup available. If you have a triggered attack, we can treat it and stop it, right? And then now we can monitor it and see what's safe and if anything needs to be adjusted.
Perfect. Thank you for that. There are definitely a number of questions actually still left, and some of them are actually regarding hormones. As we know, it definitely does affect us with porphyria. But I also recognize that it's already an hour, and I'm very gracious that you spent this hour with us on a busy Sunday. So we're going to wrap it up at that point where we're currently at. I want to thank you once again, Dr. Wang, that you're always willing to give your time, energy, and most importantly, your knowledge to this community, all the caregivers and all the patients who have the pleasure of listening to you walk away consistently a lot smarter and knowledgeable because of you imparting your knowledge to us. So for that, thank you so much. I do want to remind everyone this video will be left here in Porphyria Together. Feel free to share it with anyone that you would like to just get this information out to. Most importantly, share it with your doctor if your doctor is also just attempting to understand the ins and outs of porphyria. But the other thing is that I want to remind you that tomorrow is Global Porphyria Day. It is the day for us to go completely crazy with just announcing this disease to the top of our lungs so that we can get more people in our surroundings to be aware of this disease. So participate in the campaign. One thing I wish you understood about porphyria, finish that sentence, share it with your friends, your family. Get your friends and family to wear purple today, tomorrow, as a reminder that we are here in solidarity with all of us that suffer this nasty disease. But we have great doctors such as Dr. Bruce Wang and our scientific board that are here to work with your team as well in ensuring that you're getting the proper care. So with that, thank you so much. We have also the last day today at midnight to submit your art challenge. We have quite a number of beautiful pieces already, but I want you to get yours in there as well, with a chance to win up to $1,000 for the first prize, $750 for the second prize, and then $250 for the third prize. So you could be the lucky winner and cha-ching in your pocket as well. So thank you so much once again. Be constantly looking out for the information that UPA is putting out. We're pouring our heart and soul into this community to ensuring that you never feel alone, because you're not. We're here with you. We love you and we support you. And we are just a phone call away or an email, info@porphyria.org, so that we can answer all your questions. Dr. Wang, thank you so much for your time today, this beautiful Sunday. I really appreciate you.
Yep. Thanks, Maya. Thanks, everyone.
Thanks, everyone. Have a good one.